hechos.
I think the best way to do it is we need to have everybody sitting up on the inside. Everybody sitting and lunch to them. That's probably the easiest. I mean, yeah, please take a seat. Yeah,
I'll be right there.
And that's
Too many choices.
right. But don't offer choices. I mean, just,
Perfect.
I think that will be. Otherwise, we can't start. Okay. We're going to start the panel discussion, and we will be serving lunch during the discussion here on these tables. So you're free to come out here, find a seat, and join us in the discussion, and lunch will be served. I am very excited about the opportunity to talk to all of our panelists today. I've met them personally prior to today, of course, in the preparation of the panel. And we have agreed that we are going to follow, or what's going to lead the discussion is a natural flow of events that happen in the progression of the disease. So we have with us Kurt Krakowian. He is a patient. He has been diagnosed with vascular dementia. We have Dr. Ben Perry. He is an MD at Baylor Scott & White's Hillcrest Internal Medicine and Senior Health Center. Erica Rosa Reyes is social worker with the same entity as is Leah Schiltz. She is a nurse there. And we also have Ann Creton, who is a caregiver, a professional caregiver dealing with patients with Alzheimer's for the most part. Interestingly enough, all of us have been touched by the disease on a personal basis as well. So we talk not only from the standpoint of those who have to deal with people outside our personal world, but also as people who have been touched directly by the disease through relatives at home and so on. So without further ado, I'm going to sit down and get the conversation started. And we're going to start at the beginning. And we're going to ask Kurt to tell us how it all started. When did he started, either he or his family started noticing things, signals that prompted him to take a step, some steps, and we'll follow that path all the way to understanding the implications of the disease.
Okay, well, thank you. My wife is here, so Kathy is over here, so she's learning today about how to control me a little bit better. You think I was bad or bad, wait till you have dementia. Woo, I feel bad for my family. But how it started was I was in hospitality management, did it for 30 years. I was district director for a hotel chain, and I couldn't remember numbers. I couldn't remember things to do at home. I was always losing things. I mean, once in a while, yeah, you lose a cell phone, okay? But I was losing things all the time, leaving things on that shouldn't be on. I think I left a stove on once, and I mean, a lot of signals. So we said, okay. I had several strokes prior to that, so I went in and saw my doctor. It was Dr. Freitag, wonderful doctor. Unfortunately, he passed away. I was diagnosed by him, and then from there, they sent me to a psychologist, or a psychiatrist, I can't remember what it was, but it was another doctor to do a series of tests, what I could remember and not remember. They found out through all that, and then MRIs, that I had stage 4, which they go into different stages from 1 to 8, I think it is. And so I'm right in the middle. So in other words, my short-term memory is gone. My filter's gotten a lot better. I had, at first year or so, I did not have a filter. So I really had to work internally to keep my filter. In other words, everyone knows what a filter, that you never know what's going to come out over here. Well, it got pretty bad. But it's just, you just got to live with it. You go see your doctor and see what you can do. I do exercising now, which helps control my diet. And then just learning, from other people.
And we'll go into lifestyle habits and changes and stuff, but how long from those first signals, from those first signs, until you actually sat in front of a doctor and said, something's not right?
Honestly, I can't remember. And it could have been, 6 months or 8 months. I'm not really sure on that period of time. I just know I had COVID real bad. I had COVID 3 times, and then I had a stroke, which I've had quite a few strokes. I forgot how many strokes have I had? 4? I've had 4 strokes. So I've come a long way having to redo things. So I think it was a combination between the strokes I had, COVID 3 times, and then something happened up here. And it just went bad, so I couldn't tell you. Got a phone call.
No, sorry. All right, Dr. Perry, so here we are, you're seeing patients all the time, different conditions. So you now have a patient that comes to you for the first time to see you about changes in his or her memory, things that are worrying him from that standpoint. What do you see? What's your perspective on that? How does this happen?
Great question. I think one of the important things to maybe first point out is not all memory change is equivalent to dementia or specifically to Alzheimer's. I think it's important to recognize that, because many times I do have patients that come and they say, I'm noticing that my memory isn't as sharp as it once was. Does this mean that I have dementia? And we've all, as you pointed out at the beginning, we've all probably been touched in some way or another by Alzheimer's or some other form of dementia. And so it can be very anxiety-provoking or stressful to think, am I on that path, or am I on this road to developing this condition? And so generally the first thing that we do is try and get an accurate history in terms of timeline, specific symptoms that the individual or family members have been noticing. Is it strictly short-term memory changes? Is it impacting various aspects of life other than just remembering, what you did yesterday, or where you placed something? Is it kind of bleeding over into aspects of maybe finances, or being able to, remember different social kind of practices or social norms? Is it affecting mood or sleep or other aspects of life? And so I think the first step is just getting a thorough history and finding out how it's manifesting on a day-to-day basis. And then second would be ruling out some of the other conditions that can mimic those types of symptoms. So, there are many conditions that can affect memory, among other things, including different vitamin deficiencies, infections, different metabolic abnormalities, kidney, liver, electrolyte issues. And so doing some tests, preliminary tests, to check and either rule out or find or discover that there may be some other condition that's at least impacting or perhaps causing all of those symptoms. Thyroid disorders are another common condition that we may see. And so I think once you've gotten that history and gone through some of that preliminary workup, then being able to come back and say, okay, putting all those pieces together, what sort of condition do we think we're dealing with? And if it does seem like this truly is a neurocognitive disorder, then we have options of some additional testing that can be done to try and sort that out.
Thank you. In our conversations, Leah, you mentioned that sometimes after the patients see the doctor and leave, they may call back and they may call you, maybe with questions that perhaps they didn't have didn't feel like making the dog, asking the doctor, but they. So what type of that second connection, that second of communication is like?
So a lot of times patients, after they've seen the doctor, sometimes during their first initial visit, they're filled with a lot of information. There's a lot of information exchanged back and forth. And so a lot of times a patient will call back and ask additional questions, maybe to clarify something that the doctor and them discussed. Maybe it's something they got home and realized that a medication they told us they took was somewhat different than what they had actually listed at home. And sometimes they're just calling back to give us additional information. Sometimes it's a family member that is noticing a new symptom or didn't speak up during a visit that has now called back and said, I really noticed this going on, I think a little longer than what the patient explained in the visit, or things like that, that we just want to make sure it always gets back to the provider to give us a whole picture for the patient.
And sometimes what happens, and again, this is gathering from the conversations, is that patients, individuals who have some symptoms, want to have a diagnosis. And the diagnosis may not come because those may not be symptoms that reflect a condition, just otherwise. And it seems like they want the diagnosis, whereas the other people that actually were diagnosed are somewhat trying to deny it. So it's an interesting dynamic there. So, Anne, you are a professional caregiver dealing with Alzheimer's patients all the time. By the time you are asked to come see them, probably the condition has progressed quite a bit. You also have experience at home with the disease. So what do you see? At what point do they come ask for your help? And when you compare that to what you saw at home, at what point do you sought outside help at home?
Well, I think one of the greatest things is to go into a situation with some knowledge, some education. Certainly some background has helped me quite a bit. Every single person with Alzheimer's is different. And respecting them, respecting their needs, their feelings, their moods. Patience is so invaluable to have, and understanding. It can be a challenge. They're oftentimes combative. They suffer from sundowning. There are just so many aspects of an Alzheimer's patient that you really need to keep an open mind about the day-to-day and even the minute-to-minute or hour-to-hour, because those personalities will change drastically within that period of time. I think it is very hard for them to understand, but those conversations with them are very, very important. And treating them with dignity and respect is really what they need and what you should provide for them.
And so we've been talking about the patients, but of course there's the other side, the caregivers, and they are a very important part of this formula, of this picture. And so, Erica, as a social worker, you go to their homes and you see them and you see that dynamic. What do you see?
Yes, I do have the opportunity to do some home visits and patients and their family members, and that's always a really valuable setting. You can look at it from many different aspects in terms of safety, stimulation. Is it an environment that's overstimulating, understimulating? Are there some needs that they may have? Is there medical equipment that they could benefit from? And they being the patient or the caregiver, because as you know, as a caregiver, your physical demands will increase. And so there are things that a lot of times caregivers are not aware of can make it easier and safer to care for your loved one in their home. You can also see what safety precautions are in place in terms of things like wandering. If your patient or your loved one has not started to wander, leave without you knowing, that's a possibility that can happen. And so I like to say it's not if, it's when. And so, of course, we hope that doesn't happen, but we want to be prepared. And that's kind of my role, where I basically troubleshoot and go, let's plan for step B and step C, because we're still at step A, but we're going to get to B and C. And if we want to stay home and stay safe, let's get ahead of that and pick different things to put in place, whether it's GPS monitors on your loved one or certain types of alarms on doors or windows, things that can keep them safe and give you peace of mind. So as the caregiver, you can sleep at night, or you can continue to do your own activities as long as your loved one can remain independent. So those are some of the things that I get the opportunity to help with, as well as just that emotional and mental support for the patient and the caregiver at whatever point they're at in that process.
In our earlier discussions, you brought something that was that added a very interesting perspective to things. You said, when we have children, early on, even before we need a pediatrician, we're already thinking about who that pediatrician will be. When we are about to buy a house, the first thing that we think about is where the house should be in terms of what school system we want our kids to be in. And as we go in life, many decisions are made based on how they would affect, impact, project our children. And yet, when we come to the elderly, that phase, we don't approach things in the same way. And perhaps we should.
Yes, I in my ideal world with patients and their caregivers, it would be structured like we prepare for our children. So, of course, before we had our first child, we had 3 pediatricians we wanted to interview, and we set up appointments with all 3 of them. We already had 2 school districts picked out, all of those things, right? And none of it happened as planned. But we at least had something in place that we thought would be best in our ideal world. And so for aging, we can do the same thing. We can say, I hope that we can stay at home as long as we can. But if we can't, then honey, where do we want to go, or who's going to take care of us? And let's make that decision now while we can make those decisions, and let everyone who loves us know this is what we would like. Have those discussions. Should I change my doctor? Do I need to see someone who specializes in seniors or who has more familiarity with the Alzheimer's disease? One of the main things that drove us to pick a pediatrician, we knew that our baby was going to be born with a deformity. We knew that our baby was going to be born with a clubbed foot. I wanted a doctor who had babies with clubbed feet. And that's hard to find in Waco, Texas, but I found one, and she ended up being our pediatrician. So make sure that you have a doctor that fits those things that you need as you're aging. Things that you might not be thinking about. I don't need hospice right now, or I don't need palliative care right now. But what if or when you do? Do your research. Ask your friends. Have a plan in mind that if I get to this stage, this is the company or the agency that I would like. So all of those things, we can start to plan and prepare for them in case we need them, because there's nothing worse than having to make a decision when you needed that service yesterday. And then you feel pressured to go with the first person or agency that you meet, and you don't know what your options are. It might be a great agency, but if you'd have had time and opportunity to plan ahead, you might feel less anxiety as the caregiver and even as the patient if you know what your plan is and you already have that set up.
Thank you. Dr. Perry, how about trying to define the disease itself a little bit. We talked about the patients and we talked about the caregivers, but how about the disease? What is Alzheimer's? And are there things that we can do to avoid having it, or are there things that when we have it we can do to slow its progression? I mean, from a medical standpoint and also from a lifestyle standpoint.
Great question. So Alzheimer's is still something that there are hundreds of millions of dollars worth of research that's being done currently on this to help us both better understand the disease process, as well as hopefully finding interventions that can stop the disease process, hopefully maybe even reverse the disease process. But at this time, in terms of our medical understanding, Alzheimer's is kind of a multifactorial process, meaning there isn't just one thing that causes the development of Alzheimer's disease. There are multiple factors that they've found, including abnormal proteins that can accumulate in the brain and affect the way that our neurons or our nerve cells communicate with one another. There are implications on different inflammatory markers that can be a sign that with increased inflammation in the body as a whole, that can have neurocognitive effects in the brain cells. There's also evidence that vascular factors, so the ability that our blood vessels in our brain have to effectively circulate blood, that there are factors that inhibit that circulation that can affect or lead to the development of Alzheimer's. And so, as you can see, much of the research that's being done is trying to hit one of these different factors or multiple of these factors to try and find a way to slow or stop or reverse that disease process. At this point in the kind of the medical field, we have several medication options that have been approved for use in Alzheimer's disease. Unfortunately, none of them have been proven to stop or to reverse the disease, but the hope is that they may slow the decline down. And so some of you may be familiar with some of these medications. There was a third class of medication that was approved within the last year and a half. The use of it has been fairly limited just because of its newness and therefore its expense. But most of those medicines are aimed at trying to improve the efficiency that those nerve cells communicate with one another in the brain. In my clinical experience, the results have been pretty mixed, meaning I've had a number of patients that haven't either tolerated the medications due to side effects or that have felt like after being on the medicine haven't really seen a response. I have had some patients that have told me, and family and caregivers alike, that have felt like maybe they have seen some improvement or some response to the medications. And so usually my approach to my patients is that the decision on whether or not to take a medicine or which medicine to take is a very personal decision. I feel like I, as a clinician, don't have a lot of strong foundation to stand in front of someone and say, I strongly recommend that this medicine will improve your disease. And so I try and lay out the pros and the cons, the potential side effects, the potential benefits, and then encourage my patients and their families to have a discussion and decide if that's something that they want to pursue. I do tell them that probably, because of that, probably the biggest impact we can make in terms of having a positive effect on the disease are some of those lifestyle interventions aside from prescription medications. And so certainly we know that risk factors such as diabetes, high blood pressure, leading a sedentary lifestyle, low kind of interpersonal and social engagement, all of those things can increase our risk of developing or having a more rapid progression of Alzheimer's or dementia. And so those are some of the things that I think we have the biggest control over is, what sort of foods are we eating? Are we trying to keep any premorbid or underlying conditions controlled, such as diabetes or high blood pressure? Are we trying to keep our minds actively engaged? Are we having, opportunities to engage with other people in conversation and social activities? I think those are some of the things that we can do that have an actual impact on either preventing the development of the disease or prolonging kind of the ultimate culmination of the symptoms of the disease.
I met Kurt last probably January or so as we were preparing for the Bosque County Alzheimer's Expo in Clifton. And when we met again for our meeting in preparation of this one, Kurt mentions that, well, before he was in one medicine, he is now in two, or taking two.
Well, going with what the doctor was saying, my doctor passed. So I have a nurse practitioner, and so she loaded me up all those medicine. And to be honest, I stopped taking it because it changed my personality. It did a reverse effect on me. Do I want to have a good quality life and, be a nice person to be around? Or do I want to be, I'm going to say it, right? I'm a monster with that medicine. It did things to me that I didn't want. And it wasn't fair to my family to be going through all that. So my choice was to stop taking it. It's been now 3 weeks or something like that. I haven't taken it. And I'm back to the Kurt I used to be. So it was just my choice. I'm still taking stuff for my other things, my neuropathy and stuff like that. But as far as diabetes and depression medicine and anxiety medicine, and I was taking, I forgot how many pills a day. 22 pills a day I was taking. And that was just too much. And so with my body, I finally made a decision. I can't. So I was just being honest.
No. And that's the idea here, and we all appreciate that. Kurt, for those who don't know him, has he mentioned just the hospitality activity that he was involved in the past, but he also is an actor. And he has been in, from Yellowstone and other series throughout the... Yep. And he also is a very methodic and disciplined person who brought to light in those discussions the importance of a lifestyle, setting up your own routines, of course the diet aspect, the exercise aspect, the challenging aspect. You mentioned taking trips on your own now, just to reboot, and you use that word. Tell us a little bit about that
Sure.
aspect.
Well, for exercise, I'm trying to do it every day. I'm not trying to get all big and strong, but I'm doing the exercise at the gym that I enjoy doing. It could be the machine, like a skiing machine, it could be the ropes, it could be the crunch machine. It's something, and then I talk to people. And so before, I was hiding in my room all the time because that's my safe place. So it took me probably about 1.5 years to get out of there so I could start being sociable again. I used to be real sociable, but I got very reserved, very much to myself, which is total opposite from what I really am. So going to the gym and just meeting people. I'm going to volunteer for some nonprofits. We belong to the Waco Police Citizens on Patrol, so we meet every month. So I'm trying to do things just to get out. What was the other part of the question? Oh, the rebooting, yes, right. See, I forgot the second part. What I've been doing is I've been taking like mini trips, and my family's watching me very closely. And so I went to a reunion last month or something like that in Arizona, which I'm originally from, and I was with a group called Up With People, which is a performance group. And so it was our 40th a reunion, so it was really nice seeing people I haven't seen in 40 years from all over the world. This month, in a couple weeks, I'll be going to my 40th high school reunion in Lake Havasu City, Arizona, home of the London Bridge. And so that'll be a lot of fun. And then the following month, I'm going to go see my best friend I haven't seen, about 8 years, 9 years, in California. And with these little mini trips, my psychologist that I talked to says, you need something to keep you going to have the independence. But there's still people around that I'm going to go see that can say, okay, I'm going to call your wife, something's not right, okay? But I come back and it was just, I'm back to me. And it was really nice to be independent and not have to have someone always, there. Because I know it's hard on the family as well. But let someone else share on that fun and excitement with Kurt around,
So Anne, You, as we said before, are a professional caregiver. You see many of our clients that have the disease at Divine Monday to Friday. And I don't know if it's still the case now, but I know that on weekends you would go home and you would find the disease there too. How do you, as a caregiver, cope with the stress, the pressure that this comes with? What types of tips would you offer to those who may be in that situation?
I do have a lot of stress. It is a stressful position to be in. Some days are better than others with my clients. I also speak as the daughter of a mother who has Alzheimer's, and going to see her on the weekends in addition to my Monday through Friday, it is a lot. I'll be honest. I deal with it by going to my safe place. I still have my safe place, and I will, which for me is to go to my room. And I have to have it quiet. I have to recenter myself. I have to prepare for the next day. Because when I go into that home, that person deserves 100% of what I have to give. So I very much am basically a recluse, if you would. It's very important to me to have that quiet time. I watch movies on my phone. I do not turn the TV on, the radio on. It's just a very, very quiet, very soothing atmosphere for me, and that's what recharges my battery.
Leah, from the standpoint of a nurse, what type of recommendations do you make to the families of patients from a standpoint of a nurse?
Good question. So a lot of times families are looking for additional ways that they can help support the patient or person with Alzheimer's. And so something that we recommend a lot is just engaging with the patient, encouraging them to be active as best they can. Sometimes being active doesn't necessarily mean going outside of the home or somewhere where they're safe, but just encouraging them to have movement, both the caregiver and the patient. Doing something meaningful every day, even if that's for yourself or for the patient, giving yourself something to look forward to, and then just ensuring that you take a few moments for yourself, because just like Ann said, it's very important that you give it, the person with Alzheimer's, they deserve your full dedicated attention. They deserve what, you're there for, what the support that you can provide for them. So ensuring that you've, recharged and refueled yourself to be able to continue to provide for them, whether that's, just day-to-day support or, another thing we also do is, we rely a lot on each other in the healthcare system, getting in touch with other providers, other social workers, other caregivers that, are all dealing with similar situations, and just being able to relate to someone, and finding someone that you can relate to or confide in, can also be very helpful for both you and the patient.
Thank you. Thanks to our exhibitors here today, we are showcasing a variety of resources that are available in the community for people affected directly or indirectly by the disease. Erica, are we missing something in Waco? Is there something else that other than what we have here that perhaps we wish we had in terms of a resource for it?
Yeah, I think we have a very good representation here today. I would say and just encourage everyone to keep an open mind, because again, while you may have a plan, that plan can change. So I would encourage, don't just walk by a table because you think, I'm never going to need to go live there. You never know. You or someone you love may end up there. So I would encourage an open mind. The other thing that, just being very transparent, that I see as a challenge with the population that I'm working with, there is kind of this gap where maybe you're not at the point where you need 24-hour care, but you need some care and some assistance, and that particular type of care and assistance is not covered by insurance. And you're on a fixed income, so your finances are such that you weren't prepared to pay $500 a week to have someone come over and help you clean your house and cook some meals and stand by while you get in the shower. That's the biggest gap that I see, is just the inability to afford that home provider type of service. And even though you may have a caregiver, or you think, oh, I'm caring for my mom or my dad, we don't need anyone. You're gonna get tired, you're gonna get sick, things are gonna happen, and you will need someone at some point. So I just encourage, in those situations, use your people around you. Those people that say, call me if you ever need anything. What is your number? Because there's always, almost always someone who can do something for you. They may not be great at helping to bathe your mom, but they may be great at making meals for the next 2 days so that you don't have to do that and can have that energy and time to bathe your mom. It takes a village. Just like it takes a village to raise your babies, it takes a village to age. And so use that village.
Great tips. So before we go for and hear your questions to our panelists, I wanted to ask Dr. Perry, and we talked about this a little bit before. I guess Kurt mentioned that his neurologist passed, and so in town we seem to have one or two other neurologists, and could be said that Waco is a neurologist desert. Does everyone need a neurologist? At what point is that really the person to see, other than just a doctor?
Sure. So Alzheimer's and other forms of dementia certainly fall into the field of neurology, and neurologists are well trained and well equipped to manage that disease and condition. I would say not everyone with dementia, not everyone with Alzheimer's necessarily needs to see a neurologist. That's something that I also wind up discussing with my patients and their families. Is that something you want to pursue? You know, for many of my patients, really that boils down to one more doctor's visit. And so I'm told by many that no, if we can avoid, or consolidate as many of these visits as possible, that's our preference. And so I would say most of the time, and I appreciate Ann's kind of description, not every single patient with Alzheimer's or every single patient with dementia will look unique. We have kind of the typical symptoms that we look for, and we have kind of what we expect to see as a common progression, but every single individual's case will look unique. And so that said, most typical cases of Alzheimer's or dementia can be managed by your primary care physicians. Again, as I mentioned earlier, we're limited in terms of medications that we have to use in treating that. And so most of the time, a primary care physician like myself or a family medicine physician that you may see already will have the knowledge and ability to manage that. Many times what I see being the biggest benefit of having a neurologist is when maybe there's an atypical presentation. So there's kind of a constellation of symptoms that we say, well, this certainly could be dementia, but could there be some also other underlying condition? Or this doesn't kind of fit a typical pattern. Are we sure that we've got the right diagnosis? In those sort of cases, I think having a neurologist look over the workup, suggest or recommend any additional tests, that can be extremely helpful.
Well, thank you very much. And so I'm going to come down and pass the mic to whoever would like to ask our panelists something that I certainly have missed. Anybody? Questions from the audience? Yes, ma'am.
Dr. Perry, I was not aware that there was a grouping of doctors, maybe whatever, that we're really good with seniors and geriatrics.
Well, I guess really good is, I guess, a matter of opinion, but we do, so Hillcrest or Baylor Scott and White, we have a senior health care clinic. Myself, I'm trained in geriatrics. We have a nurse practitioner that I work with, Candace Balajian, who has been also kind of in that area of geriatric care for quite a number of years. I would say as an area, as a city of Waco, Central Texas region, we don't have many geriatric doctors. I mean, that's certainly an area of medicine that there are fewer and fewer physicians going into. That said, with an aging population in our country, more and more primary care physicians, if you look at their patient panel, a larger and larger majority of their patients are seniors. And so I guess, you know, I also have conversations with patients all the time that are coming to me, and, you know, we get talking and they say, well, I've been seeing Dr. So-and-so for the last 30 years. You know, he knows all of my medical history inside and out. I say, well, why are you coming to see me? And they say, well, we heard that you're a geriatric doctor. And I say, well, that's true, but that doesn't necessarily mean you have to change doctors. And I think piggybacking off of what Erica mentioned earlier, I think really probably the biggest principle I would say that's important for people as they age is just trying to be proactive in their preparation. Do you need to change doctors once you hit a certain age? Maybe, but not necessarily. I think there are wonderful family doctors that have really developed that rapport and relationship with their patients over decades, and they may be able to best serve their patients. In some cases, it may be a good fit to say, well, we're having these new symptoms that are developing. We're not sure. Could it be underlying conditions? Could it be medication interactions? We just want a fresh set of eyes. And so, you know, I think it just depends on the individual and their situation.
Anybody else? Questions, comments? Mrs. Krakowian, you have already been brought to the discussion for a little. Is there anything that you can share with us from your standpoint? Is it not to put you on the spot, but can you tell us how it all looks from your end?
It's been an interesting experience the last year and a half. Handling my own emotions and how to adapt with him, handling our future plans. It's just not good. I think I'm an emotional basket case right now with everything that's been going on. The medications, the up and downs with the attitudes, the meanness, not knowing what to do, and our whole marriage changing. That's been the hardest part. And I do agree that as a caregiver, you need to take care of yourself, but it's very hard to recognize when you can step in and start caring for yourself when you live with that person 24/7 and you're taking care of, not to the extent of where you're giving them baths, you're doing everything like that, but you're checking their meds, and then everything you do is wrong. So, and then you're like just in a survival mode, and you're working, you're paying bills, you're doing things like that. It's just learning this time when you can learn to take care of yourself and taking that time out to take care of yourself. Because there is a frustration, to be honest, with the doctors, because the doctors don't tell you everything. They don't tell you what to expect in the next stage or what you should do. So I'm trying to be a doctor and think of, well, what's my next question I need to ask? Or if I see him in this mood, is this a real mood, or is this because he's just on some medication or something like that? So that's my frustration as a caregiver, and I don't know if anybody else has had that frustration. And you read and you read and you read, and there's no consistency in the web, on the internet, on how to handle this. You do hear a lot about people, well, if they're at this stage, you know, you can get them a caregiver. Well, my husband, as you obviously see, is not at that stage where he needs a caregiver.
but he does need help from somebody else on how to handle this disease, because I'm not an expert at it. You know, and you rely on groups like this, which I appreciate. I have learned a lot today from. And, but it's just, I don't know, it's just a frustrating disease. It truly is.
Thank you very much. Thank you. And thank you. And not just questions, really, but if you all have something to share, something that you'd like to tell the rest about your own experience or somebody else's experience, that you know, we'd welcome that. I think we have created a situation here where we all seem to be, to some extent, on the same boat. So every comment will be welcome. Anybody? Tiffany? Sure.
Do you feel like patients who are exhibiting all these symptoms would benefit from having a brain scan, MRI, or anything? I mean, I know there's all kinds of lab tests that you do, but what good is the scan? Does it show
Great
you?
question. So I think I would say that's kind of a case-by-case answer. You know, many times an MRI or a CT scan of the brain is not part of a workup, but there are certainly cases where we may be concerned that, you know, this could be dementia, but it could it be a small stroke that's occurred in the past that's caused, you know, led to some of those symptoms, such as in Kirk's case? Or could there be there's a condition where you can get increased fluid buildup in the brain, and that can sometimes cause some symptoms that look similar to what you see in dementia. And so I would say it's a case-by-case question and based on kind of that history of symptoms and progression and timeline. But certainly that can be useful and helpful in either discovering that there's some other underlying condition that may be contributing to those symptoms, or to rule out the possibility that this is something else.
Tiffany? Oops, sorry. Whoa. Sorry, guys.
I just wonder if on the panel there, or you talked about stage 4 dementia, Alzheimer's, are there certain markers to indicate like end of life or stage 8, you know, without actually doing brain scan or having a doctor, you know, going through that sort of process? Or there certain things that you look for in patients that are that far advanced?
Well, I know there's a series of that. If I remember, I don't remember, but there is a good chart that they have over there at the table over there for Alzheimer's table. Tiffany has that. But if you go to their website, it actually shows the different stages. But I think the doctor can go in a little bit more into the different stages. You probably know them left and right.
Honestly, from the stage standpoint, I usually don't, I hope this doesn't sound bad, but I usually tell my patients, I frankly don't care what stage you fall in based on, you know, the table of criteria that they have. Because from a practical standpoint, my focus is how can we try and maintain or improve your quality of life, and how can we try and maintain that for as long as possible. And so from a clinical standpoint, you know, that may mean that I document in a chart someone has stage 3 as opposed to stage 4. But for the patient and their family members, what that stage is really doesn't mean anything different, other than what are the symptoms that I'm experiencing on a day-to-day basis, and how or what can I do to hopefully either address those or mitigate some of those factors. And so as far as the question, is there a test that can be done, either a blood test or an imaging, you know, one of the most frustrating things, aside from all of the other frustrating aspects of dementia, one of the frustrating things from a clinical standpoint is there really isn't a test, right? I mean, unlike conditions like diabetes or even rheumatologic disorders like lupus, rheumatoid arthritis, we don't have a blood marker that we can check on someone and say, oh, this came back abnormal, so you have Alzheimer's, or you have frontotemporal dementia or vascular dementia. It's a clinical diagnosis. So it's based on what are the symptoms that you're having, how long have they been developing, how rapidly have they been coming on, and what are we seeing kind of manifest outwardly in a physical way. On that same line, there's no specific finding on an MRI or a CT scan that we can at least practically use to say, well, your scan looks like this, so now we can say confidently you have this condition. And so usually the testing that we do is really primarily to support the hypothesis, either that, yes, this individual is developing some form of dementia, or to rule out other conditions that may look similar to that. Does that answer your question?
Thank you. One of our experts mentioned let other people help you. So this is a tip for caregivers. If you have index cards, write different things like grocery shopping or trips to the doctor or vacuuming my house or dropping by with snacks or staying with my loved one while I go grocery shopping. So if you write one item per index card, and you've all got friends and relatives who say, well, what do you need? I'd like to help you. And you go, blank, I need somebody to take over my job. Well, give it piecemeal to people. Say, look through these cards and see which of these tasks would be easy for you to do. I don't cook. I will be glad to run errands all day for somebody, but I will not prepare them a meal. So give me something that's easy for me to do. It might not be easy for somebody else, but easy for me. So do the index cards. You can get colored ones for different types of things, or they can be all white.
We will have a demonstration from Jay Lee a little later today about a matter of balance, right? The importance of keeping in balance.
I'll show you how to get down on the floor and get up again.
Tiffany now? Sorry.
Okay, so my name is Tiffany Soto, and I'm not going to use this time on the mic to promote my amazing program that I am a part of, but I just want to speak to the caregivers. I know that a lot of times, and with everything that you go through and with everything we're carrying, you do not take care of yourself. So one of my REACH participants is here with me today. Well, as well, I have a few REACH participants here today, but what she's always told me is the one thing that she always remembers is that I tell her to give herself grace and mercy. Every single day as a caregiver, you're waking up and you're taking on a journey that you're not aware of. This is not something that you could have prepared for. It's not something that you can see forward to what's going to happen. But what you have to do is protect yourself, your mindset, your stress levels, and take care of you, because if you don't take care of yourself, you're not going to be able to take care of the one that you love. And with that, just give yourself every day the grace and mercy and know that you're doing the best that you can in the situation, in the time, and the place that you're doing it. But then, if you would like to utilize some of those free programs at the Area Agency on Aging, you can contact 211, and they can tell you about REACH and stress busting and all of those great things. But just know that, just give yourself that, because you know that you're doing that the best you can. Nobody wakes up any day and say, I'm going to use this day to do the absolute worst that I can do. Everybody wakes up and they try to do the best they can. And my other tip is, while you are going through this journey with your loved one, you take the times that are the most important. You take the times that are good in that moment and you remember those. So when there's a difficult moment that comes around, you can always have that glimmer, because there's always a light, at the end of the tunnel. And just use your support systems and call me.
Thank you very much, Tiffany. Thank you all very much for participating. To our panelists, thank you. It was a great discussion and very much appreciated. I'd like to ask Erica to give us a quick announcement of a presentation that is going to be happening now in the program. I'm sorry? Can you explain just a quick what the breakout presentation will be? The Expo continues, and we have more content and more things for you as well.
Hi, so I'm Erica Mendoza, and I'm with Adult Protective Services, and I'll be giving a brief APS 101 at 1:15 in the breakout session room if you'd like to come and learn a little bit about some of the things that APS workers kind of see and do, and not just the bad of APS, but the good that APS can also do for the community.
Dealing with abusive behaviors.
Yes. So we'll also discuss abusive behaviors and those signs and symptoms to also look out for as well.
Perfect. Well, keep enjoying the Expo that we have prepared for you. Thank you for your participation. Thank you all.